Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for inviting me for this important and successful conference, which is the first Al-Baha conference for diabetes mellitus and its management. My topic will be discussion about the neuropathic pain management. And actually the importance of this topic comes from the high rate of morbidities and mortality associated with this single entity, which is pain of lower extremities in diabetics. That's why pain as a presentation in diabetes mellitus is only the tip of an iceberg. The importance of pain management comes from the high annoyance from this unpleasant sensation to this category of patients. The objectives of my topic will be understanding pain of lower extremities in diabetics, the pathophysiology of such entity and its clinical implications, to plan a framework for assessment, diagnosis, and treatment, planning for pain management, and to engage with other members of the healthcare system in order to achieve better outcomes about pain management. We will cover the prevention and treatment of pain of lower extremities of neuropathic origin in diabetics. Pain, according to the definition, recognized worldwide, is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. It's always an individual, subjective feeling or experience which has psychological implications. This definition comes from the International Association for the Study of Pain. In timely context, pain may be acute, chronic, or acute on top of chronic. However, in terms of the pain stimulus, it may be nociceptive, neuropathic, or inflammatory. We can differentiate nociceptive pain from neuropathic pain according to its nature, where neuropathic pain arises from sensory abnormalities causing varying degrees of pain sensations, from numbness to hypersensitivity, and frequently associated with allodynia. Allodynia is described as abnormal pain sensation arising from non-painful stimulus. The duration of neuropathic pain is prolonged and frequently turns into chronic pain. And the cause is a microvascular disease of peripheral nervous system, less commonly central nervous system, and maybe polyradiculopathy. It may be mono or mononeuropathy or polyneuropathy. Examples of neuropathic pain other than that of diabetic neuropathy can be post-herpetic neuralgia from HIV or other types like drug-associated polyneuropathy. Around half of patients with diabetes at a duration of 10 years of the disease will have a diabetic neuropathy. This neuropathy will be sensory motor, poly or mononeuropathy, and we have a group of patients having touch neuropathy, which is also more than 50% of those patients where they will have foot ulceration, later on amputees, neuropathic pain, significant morbidity and mortality, and use of polypharmacy and various types of healthcare resources. Diabetic neuropathic pain in nature is tingling, burning, sharp shooting pain, like shoots of electric stimulations, lancinating, or like we said, like electric shocks. It is usually moderate to severe in origin. It is manifested at rest and worst at night, causing sleep deprivation and psychological troubleshooting. It might be constant and accompanied by cutaneous allodynia, which is the presence of pain stimulated by non-painful stimulus, non-nociceptive stimulus. It impacts the quality of life of the diabetic patient. The mechanism is complex and it is studied in literature without a clear form of explanation. Risk factors for diabetic neuropathy will be higher levels of blood glucose, so poor glycemic control, old age, longer duration of diabetes mellitus, especially those more than 10 years, elevated levels of triglycerides, obesity, and higher levels of body mass indices, smoking and alcohol consumption, and hypertension. Screening for diabetic neuropathy is discussed elsewhere in the conference, so we will pass this slide, and we will come to the glycemic control. It has been shown that glycemic control is effective for primary and also secondary prevention of diabetic neuropathy. Actually, tight glycemic control have been shown to be very effective in two types of better neurologic outcome: the neurologic examination and the nerve conduction. Actually, reduction of HbA1c by 1% is equal to improvement of 1.3 meter per second improvement in nerve conduction. What about pain control? Pain control in diabetics should be always multimodal. We don't rely on single drug or single technique. And with multiple modes of pain control, we will achieve just 40% of pain control. The multimodal analgesia will encounter pharmacotherapy, physical medicine, interventional approaches, psychological treatments, lifestyle changes, and complementary alternative medicine. Most importantly, the patient is the first treatment for himself. He should treat himself by himself. How this comes? This comes through being positive towards pain. The patient himself or herself should not allow pain to control him or her. Otherwise, he or she should make pain a stimulant for a positive self-control, whether internal or external, in order to control pain by the sense of pain. This needs time and experience from the patient himself or herself, together with a strong will. pharmacotherapy for the treatment of pain associated with diabetic neuropathy relies mainly on anticonvulsants and antidepressants. However, to a lesser degree, we can incorporate opioids and other alternative therapies. For evidence-based results, we can classify the effectiveness and degree of strength for the use of various agents according to evidence-based medicine showed here. So, the treatments for pain come into two main lines of treatment with some alternatives. The first line treatments, as we said, are anticonvulsants and antidepressants. Opioids come as a second line or second choice, together with other topical and alternative therapies such as topical capsaicin applications and TENS or transcutaneous electrical nerve stimulation and physical therapies. We'll go to the first line treatments, which are anticonvulsants. Anticonvulsants have been shown to be very effective in treatment of diabetic neuropathy. The first agent studied was gabapentin, can be used at 300 milligram BID up to 4 times daily, and should be started as a small dose and gradually titrated to effect, where maximum of 3.6 grams per day can be used. However, the best results shown with a grade A level 1 evidence have been owned by pregabalin or Lyrica. Lyrica can be used at a dose of 75 milligrams BID, titrated up to a maximum of 600 milligrams daily, and it comprises one of the most expensive pharmacotherapies used for treatment of diabetic neuropathy. Sodium valproate can be used also for such entity, and as we said, gabapentin and valproic acid had less evidence than that owned by pregabalin. So the best pharmacologic agent for treatment of pain associated with diabetic neuropathy of lower extremity is pregabalin. Other antidepressants for neuropathic pain include amitriptyline, duloxetine, and venlafaxine. However, not all of these are approved by FDA for diabetic peripheral neuropathy. The second line for treatment of diabetic neuropathic pain is owned by opioids. Several opioids can be used for treatment of resistant or refractory pain, such as morphine tablets, oxycodone, and tramadol. A new drug, tapentadol, is promising. However, it comes at a higher cost, higher than that of pregabalin. It can cost up to $120 per month. However, in practice, we should not rely on opioids in the treatment of diabetic neuropathic pain, except in refractory cases. Then we come to alternative therapy and other complementary treatments for pain, which will include capsaicin treatment, capsaicin applications like sprays or patches. Capsaicin is a drug which is an irritant and strong alkaloid. When applied to skin in the form of patch or spray, it will stimulate the skin and irritate it, resulting in the release of high amounts of substance P. The neurotransmitter used by type C small fibers, transmitting pain, which is the acute type of pain causing tingling or electric shocks associated with diabetic neuropathy. And should be used only as a complementary therapy. The same principle applies for nitrates and for transcutaneous electrical nerve stimulation. All come as complementary treatments. Who are at a greater risk for failure of treatment for diabetic neuropathic pain? The elderly patients, those of certain racial or ethnic groups, women more than men, and people with history of substance abuse or opioid addiction, those also who have cognitive impairment and who had a problem of expression, whether related to previous somatic disease like stroke, previous stroke, or otherwise. These are patients who are at a greater risk for failure of treatment. And as we said in the start of treatment of pain, at best we can achieve 40% improvement. So complete relief of pain is unlikely. If we get 40 to 50% relief, we consider ourselves really successful in the management of diabetic neuropathic pain. At the end, we should emphasize that glycemic control, especially tight glycemic control, control of high or uncontrolled lipid profile, control of body mass index, cessation of smoking, and control of uncontrolled hypertension are the key risk factors where, by manipulating this risk factor, we can achieve prevention and better results for the treatment of diabetic neuropathic pain. Because in this entity, prevention is always better than treatment. The glycemic control, especially the intensive types of glycemic control, can achieve both primary prevention and secondary prevention of diabetic neuropathic pain. 100% relief of diabetic neuropathic pain is unfortunately not feasible option in the treatment plan. However, if we achieve 40-50% improvement, it's really an achievement in such a difficult task. And by screening for diabetic neuropathy early, as much as possible, we can get further steps forwards for prevention before pain starts. Thank you very much. By this, I conclude my topic, and I hope the message is conveyed in the proper way. Thank you very much.